As a continuation of the previous video, today we'll be discussing about the indications, surgical steps, complications and contraindications of stapes surgery. The main surgery is performed on stapedotomy and stapedectomy. The problem is the stapes footplate is fixed and it is immobile. So we create a small hole on the stapes footplate and then attach a piston to the incus so that the piston performs the function of stapes and the mobility of the ossicular chain is restored. That is the main aim of the surgery. So what are the indications for surgery? The most commonly performed surgery is stapedotomy. So the indications are a clinical picture of otosclerosis and a tuning fork test showing negative Venus test at 512 Hz, and also a Puritan audiogram showing more than 30 decibel conductive hearing loss, mainly at the lower frequencies, that is 250 Hz to 1000 Hz. With the scan reports, everything, the surgeon feels that the patient will benefit from a stapedotomy. We can take up the patient for surgery. Even cochlear otosclerosis, minimal sensory neural hearing loss is not a contraindication for stapedotomy, because once we perform the stapedotomy, the patient may use a hearing aid and benefit from the hearing aid will be more for the patient. So how do we do the surgery? So pre-operatively, you can give the patient antibiotics. All the surgical prophylaxis, the first generation cephalosporins can be given. And we can also start the patient on steroids because we are creating a hole into the vestibule. We are creating a hole into the foot plate and entering the vestibule. This can cause some amount of labyrinthitis. So to prevent that and to prevent the complications of labyrinthitis, you can start the patient on a short course of steroids, which can be continued 1 week post-operatively and then stopped. So the surgery can be done under general anesthesia or local anesthesia. Certain surgeons prefer local anesthesia because the patient can immediately on table communicate that the hearing has become better, and also if any complications like vertigo has occurred, the patient can complain on the table that I am having vertigo or giddiness. Some surgeons prefer the general anesthesia because more cooperation from the patient, less movement during the procedure and all that. The usual positioning of the patient for ear surgery is supine with head turned to the opposite side and shoulder little bit tilted, like 10 to 15 degrees tilted. Draping, everything is done. Then you give the infiltration. The 4-quadrant infiltration is given and the tympanomeatrial flap is elevated. For proper exposure of the oval window niche, you need to visualize the tympanic segment of the facial nerve and also the pyramidal eminence where the stapedial tendon is attaching. This has to be visualized. For this, the posterior canal overhang must be removed. So you can curate the bony annulus posterior superiorly. You can either use a drill or use a curate, or you can use both. You can use the drill and slightly thin it, and then you can curate with the curate. When you are curating, always the movement is outward, because an inward sudden movement can cause injury to the incus, and also quadra tympani nerve should not be injured while you do this. Then the mobility of the ossicular chain is checked. So malleus incus stapes mobility is checked, and if stapes is fixed, you can proceed with the surgery. So the first step is dislocation of the stapes from the incus. So dislocation of the incudostapedial joint. So you introduce the nice slight outward pressure on the incus will show the gray line of the IS joint. That area you can dislocate the IS joint. Make sure that you don't put too much downward pressure on the stapes, can cause fracture of the foot plate. The movement should not be from side to side because this can cause again fracture of the foot plate. So the IS joint is separated, and then the stapedial tendon is cut close to the pyramidal eminence. Then you can fracture the structure of the stapes downward towards the promontory and it can be removed. Then a small fenestration is made on the foot plate. So the fenestration can be made using a micro drill, or we have special picks for fenestration, and also you can use laser to create the fenestration. So fenestration is made on the foot plate, mostly in the posterior aspect of the foot plate, posterior central aspect of the foot plate. And then you have to measure the length of the processes that has to be used. There are a lot of different types of processes available. The processes is usually made of Teflon, titanium, etc. Actually, the length is measured from the medial aspect of incus to the center of the fenestration plus 0.25 mm, because the piston has to go into the vestibule around 0.25 mm. So that is the length of the piston used. Usually it is around 4.5 mm, the length of the piston. And the width of the piston, usually we use 0.6 mm. So fenestration has to be created slightly bigger than the piston. So that is 0.7 mm fenestration you can create. And once the fenestration is created, you introduce the piston. So the piston can be of different types. Usually the piston will have a hook that you have to crimp to the incus. So introduce it into the fenestration and you have to crimp to the incus. There are other processes that does not require crimping to the incus. like Robinson process, which is a bucket handle type. There are also self-retaining processes that are clipped to the incus. Other process like smart processes, which use the elastic memory to coil around the incus. So you can use the processes according to your institution or your preference. The process is introduced using a smooth alligator forceps held at the loop, and then it is introduced slowly with a smooth alligator forceps. So in the first go itself, you are not able to introduce the processes into the fenestration. You just keep it at the oval window niche and then try to slightly push it inside again. Then you have to tighten the loop around the long process of incus, that is using a crimper. So you have to initially tighten it at the narrowest part of the long process of incus. Then it can be moved proximally to get a proper angle. Some of the tips are when you elevate the tympanomeatal flap, it is elevated superiorly until it is separated from the notch of the ravenous, so that exposure is well, because the incus has to be exposed properly to allow the crimping. The space should not only allow us for visualization, but also we should be able to put instruments. So the small mucosal folds between the incus and malleus, small mesenteries can be cut while doing the procedure. Also, you can keep a small cotton ball soaked with adrenaline at the level of oval window so that the bleeding is reduced. We do not put direct suction over the oval window, because direct suction of the oval window can suction out the perilymph, and it can cause sensorineural hearing loss and vertigo and all other problems. Sometimes, if the fenestration is bigger, you can use a perichondrial graft or tragal perichondrial graft around the processes so that the fenestration is covered. So that also can be done. Once the piston is kept in place, once the process is kept in place, you can check the mobility of the ossicles. Do not do it more times, because we don't want to irritate the perilymph. So just check for the mobility, and then you can reposition the tympanomeatal flap. Short word on lasers. Lasers are very useful because lasers can create a hole without much movement or any pressure generation in the perilymph. So lasers are useful in doing stapedotomy procedure. The main advantage is lasers can create a hole in a very thin foot plate, or if it is a floating foot plate. There are two types of laser. You have the visual laser, like the visual spectrum laser, that is KTP, argon laser. So that can be used using a handheld fiber optic scope. The thing about this argon laser is it is absorbed by the pigmented tissue. So for the initial starting, you will have to keep a drop of blood over the foot plate so that the laser acts. So we make a small fenestration, like a rosette shape, round fenestration. So once the first charring is done, the charring can be used for pointing the laser, and then it will come together and the fenestration is created. Another laser that can be used is carbon dioxide laser. Carbon dioxide laser will require an aim beam. The thing about carbon dioxide laser is it is not absorbed by the perilymph, and it is very useful to prevent any postoperative sensorineural hearing loss or giddiness for the patient. So laser can be used for the procedure. What is stapedectomy? It is partial or complete removal of the foot plate. The posterior part of the foot plate is removed. It is also known as large fenestration surgery. It is usually done when there is any floating foot plate, any fracture of the foot plate, or inadvertent removal of the foot plate while we are removing the suprastructure. In certain revision surgeries, you do stapedectomy. Stapedectomy also is done in the same way. The foot plate is removed, and then you keep the piston, and the area around the piston is supported and closed using a fat or a graft. What is the post-operative care? The patient has to keep the ear dry. The patient should not do any strenuous exercises, any blowing of the nose, any lifting heavy weights. Patient is asked not to take a flight for the next 2 weeks, do scuba diving, because we don't require any pressure changes inside the ear. The steroids can be continued for 1 week, antibiotics can be given for 1 week. And a repeat audiometric evaluation can be done around 6 to 8 weeks after the surgery to assess the hearing improvement. The complications can be divided into intraoperative complications and complications that develop later. So intraoperatively, you can, what are the complications that are incurred? While you can subluxation of the incus. This can happen while you curate or while you dislocate the IS joint. The incus can be subluxated. So if a small subluxation is there, we can proceed with the surgery, but it will be difficult to crimp the processes onto the subluxated incus. But the incus is fully dislocated. We'll have to use the processes that can be fixed to the malleus. Another problem is any injury to facial nerve or overhanging facial nerve. That is usually the facial nerve canal can be dehiscent. A small amount of area can be dehiscent, or it can be completely dehiscent, but facial nerve is within the canal. But sometimes the facial nerve can overhang or prolapse outside the canal and it abuts the promontory inferior to the oval window. In that case, if such a condition is found, we have to abort the surgery. In a dehiscent in the facial nerve, you can use a double bend technique that the piston can be bent both sides and then the surgery can be proceeded. Another problem that can be encountered is an obliterative otosclerosis. The bone is so thick that you cannot use a laser to pierce it. So you have to use a drill and make the bone thin until a blue layer is seen, and then you can do a fenestration surgery. Another complication is otosclerosis over the round window. If there is a round window, can be partially or completely occluded with the otosclerosis. If there is a small opening in the round window itself, the hearing will be very good. But if it is completely obliterated, the patient will have significant conductive hearing loss. But if you try to remove the otosclerotic foci over the round window during surgery, the patient will develop sensory neural hearing loss. So we are not supposed to touch the foci over the round window, but you proceed with the surgery and just note that the patient is having an otosclerosis obliterating the round window. So post-operative hearing improvement is not significant. It means that it is because of the round window occlusion. Another complication is perilymph gushers and oozers. That is, as soon as you fenestrate, that put an opening on the stapes footplate, the fluid will start coming out. Even though it is not a perilymph gusher or oozer, it is a CSF that is coming out. It is an inner ear malformation. Perilymph oozer is a small trickle of fluid is keeping on coming out. That is usually seen in a persistent cochlear aqueduct. A perilymph gusher is a strong, forceful flow. It is usually due to a defect in the cribros area of the internal auditory canal. So the CSF is only draining. In patients with the congenital conductive hearing loss, we have to do an HSCT temporal bone to rule out these inner ear malformations. We have to suspect conditions like X-linked recessive gusher syndrome. A perichondral graft can be used to stop the gusher. And immediately on table, you can go tilt the table into a Trendelenburg position so that the gusher will keep on coming and then it will stop. Then you can go into the reverse Trendelenburg and continue the procedure. And also in some situations, you can introduce a lumbar drain to reduce the CSF pressure so that you can proceed with the surgery. Another thing that can be encountered is a persistent stapedial artery. So it is an embryological remnant. Usually this persistent stapedial artery can be cauterized to the bipolar artery. Usually it is present in the anterior part, so you can do a fenestration in the posterior part of the foot plate. Another problem is malleus ankylosis. That is, malleus is ankylosed to the roof or the wall of the epitympanum with a bone or a spur. So in this conditions, you may have to remove the ingus and the head of the malleus and use a malleus attachment prosthesis. So the meningoesclerosis can be associated with malleus fixation. On pneumatic otoscopy or when you do tympanic membrane mobility testing, there will be reduced movement of the umbo or the handle of the malleus. So that time you have to suspect the malleus fixation. So another complication is floating foot plate. So the foot plate has irreversibly depressed into the vestibule. So more we try to remove it, the more problem it creates. It can create sensory neural hearing loss and long-term vertigo. The main thing that causes a floating foot plate is a biscuit type of otosclerosis. The moment you start to create a fenestration, it will start moving. In these cases, you can use a maneuver known as log roll maneuver. Laser can be used to create a fenestration and introduce a prosthesis. So once the foot plate is depressed into the vestibule, it almost always causes long-term problems and hearing loss. Other complications are an improper healing of the tympanomeatal flap, causing a hole in the tympanomeatal flap. Then the middle ear can get infection, causing any acute otitis media, post-operative otitis media. Then another complication is injury to the chordae tympani nerve, causing taste loss. Then the next complication that can happen is vertigo. There can be two types. Initially, due to the manipulation and surgery and creation of a fenestration in the vestibule, the patient will almost always have a serous labyrinthitis. So it will be due to irritation of the labyrinth. So temporarily, the patient will have a giddiness, which settles within 48 hours. Most commonly caused due to suctioning over the oval window, and also if any blood goes into the vestibule, that can be irritation. So this usually recovers within 48 hours. But if it is persistent beyond 48 hours, it can be associated with a sensory neural hearing loss also. Another thing is utricle and saccule are very near the foot plate. So if there is a Meniere's disease or a endolymphatic hydrops, the saccule will be just below the foot plate. So it can cause injury to the saccule while you put a fenestration. So Meniere's syndrome is a contraindication for doing a stapedotomy procedure. Another complication is initially patient may have a good hearing, but later the hearing loss can happen because of there can be any necrosis of the incus, or the process can slip from the original position, or the wire is too long, or there can be formation of adhesions or calcifications. And the otosclerosis can continue, and the bony reclosure can also happen. Another complication that can develop is a perilimb fistula. You have to explain all these problems to the patient before taking up the patient for surgery. What are the contraindications for stapes surgery? The contraindication number one is only hearing ear. That is, there is a chance of 1% loss of total hearing even in the best surgical hands. So if it is an only hearing ear, better not to go for a stapedotomy procedure. You can prescribe a hearing aid to the patient. We usually do not do a stapedotomy procedure in young children. Another contraindication is patients are employed in places where there is frequent pressure changes of the ear, like the athletes, high construction workers, scuba divers, parachuters, all these people. So the sudden pressure changes is happening day to day in their lives. So if you do a stapedotomy, they have a more chance of developing perilimb fistula, giddiness, and sensorineural hearing loss. So mostly this has to be explained to these people, and mostly once if they have to undergo stapedotomy, they have to refrain from doing that job. They have to look for some other job. Also, if the patient is someone who requires taste for his work, chordatimony may get injured and he can have a change in the taste. So that also has to be explained to the patient. Relative contraindications are a middle ear or external ear infection, perforation of the tympanic membrane. These are all relative contraindications. This has to be corrected before the patient is taken up for surgery. So in our surgical notes, we should note the shape, mobility of the malleus, incus, and stapes, the presence of otosclerosis, the position of the facial nerve, if there is any otosclerosis out the round window, post-procedure status of chordatimony, all that has to be documented in our surgical notes. Hope this helps you. Thank you.